All right. Let's see.
So I'm asking.
I don't
Got
know
it.
what's happening right now. It's asking me all kinds of questions about AI.
So it's because so did you notice that Zoom has an AI
Yeah, that's pretty
component to it now?
cool. Yeah, that's pretty cool.
Have you used it?
Not yet. This will be our first.
It's really cool.
All right. So we're going to do Zoom and we're going to have AI play a part in this in our conversation. So this will be fun. I need to open up AI
We'll have
Companion.
to have an entirely separate Zoom
Yes,
discussion
I would
about,
love that. I would love that.
because
So
I've been using it.
yeah, so we're right after Thanksgiving. So we're all very, very, very grateful. This is the most grateful we've been all year. And yet there are still more needs. There are still more things that we have to pursue. And so today I think we'd like to talk about networking, growing new patients, even from a specialist perspective or a GP who specializes in something. You know, there's this referral basis, there's this networking, there's SEO and direct to consumer. So where do you want to start with that? How do you want to get us started with that sort of conversation?
So I think what we're hoping to do is fill our bucket with things that we're going to be grateful for next
There
Thanksgiving.
you go. I like that. How to make sure we are thankful next year. That's great.
So, so, it's interesting because I realized that I think everybody has strengths. I know you have even tests for assessments for it, right?
All
So
across
one
the
of my
bottom there.
strengths,
Yeah.
has been the ability to network. And you never know where networking can take you.
Mm-hmm.
And it's taken me in crazy directions, all compatible with my vision and mission, right? Which is so important because you can go down rabbit holes really easily that are not compatible with your mission and vision,
Yeah.
and then you don't get to where you want to go. So networking. I think networking is becoming even more important now. So we were talking before about specialists.
Mm-hmm.
So specialists are having more of a challenge getting referrals because of the way the dental marketplace is segmenting into more and more DSOs.
Groups. Yeah.
So everyone, and it's complicated. And I have a knowledge of the academia side of things, and there are lots of specialists being turned out.
Okay.
And because academics, dental schools are not turning out really, really well-trained clinicians, there's a tendency amongst graduates to want to specialize. So it starts in the dental schools, and then it becomes, here's the market. We have all these specialists.
Mm-hmm.
Where are they going to work? DSOs know that it's in their best interest to keep everything in-house. Why send anything out? And if there's a lot of specialists around, what you can do, I did this. I started doing this 40 years ago. I hired specialists to come into my office. I built a multi-specialty group practice because my office was right across from the dental school. There were all these postgraduate students being trained in specialists and specialties, and some of the faculty say, "Hey, come on in. So I had an orthodontist, I had a periodontist, I had an endodontist in the practice. So let's talk about periodontists.
Okay.
So periodontists have a multitude of problems, one of which is a failure in many practices to diagnose periodontal disease.
Hmm.
So they're not getting as many referrals from even from their regular normal pattern of referrals as
GPs.
they probably should.
Yeah.
So a solution to that, lunch and learns.
Mm-hmm.
Have the periodontists come in to their referral offices and give a talk about certain types of periodontal issues that are undertreated or underdiagnosed.
Yeah.
Right.
Well, we know the
So
super prophy is rampant right now. So
right. So I had a really interesting conversation yesterday with so I'm on faculty at Temple University, and they had an alumni thing at the Greater New York meeting. So I went and I had dean with the I had dean with the breakfast. I had breakfast with the dean. And then later on, I went to this alumni. And one of the alumni was a dentist who grew up in America, but is now practicing in Dubai.
Oh, wow.
Actually, he lives in Dubai. He practices in Abu Dhabi.
Mm.
And he really doesn't practice much.
Mm.
He has like a 20 some odd chair clinic.
Mm-hmm.
But he was telling me that someone he knows, so they're all sort of national health sponsored clinics.
Okay.
Everybody's in the national health. I guess I didn't even ask them. There are probably some private, but most of the care is given by is paid for by the National Health Service.
Mm-hmm.
They audit periodically, and they found out that they were miscoding certain treatments, and I believe they were periodontal. Mm. And someone had to give back $5 million to the National Health Service. So, miscoding is a big problem.
Yeah.
Both undercoding and overcoding.
That's what I say. Yeah, a lot of times here it's the undercoding, the super prophy becomes the issue. But going into a practice, a GP's practice, and just educating them, where is that line that you draw on cleaning someone's teeth and getting into periodontal therapy of some sort? How do they, how can they calibrate with their periodontist within their practice to know that this is 3 millimeters, this is 4 millimeters, this is health, this is unhealth? Yeah.
So we call that supervised neglect.
Yeah.
How do you avoid supervised neglect? And supervised neglect, by the way, is oftentimes done with the best of intentions. The best of intentions. They're not, or misintention. They're not going to pay for it.
Yeah. I don't want to be seen as the bad guy. They've been under my care as their hygienist for the last 15 years, and now there's an issue. So I do think the periodontist has a place in that. And how do you get the GP's office to say yes to that lunch and learn, to get your foot in the door with that practice? How can you, I don't know.
You buy them lunch.
Yeah. Here's a free lunch, right?
Food works.
Buy them lunch or even dinner, or maybe a dinner and learn. Yeah.
I mean, I like the lunch because the hygienists are going to probably balk at a dinner. Unless you're able to give them CE.
Okay.
We all need CE.
Yeah.
Right. So if you can,
most can
partner with somebody. Now, you might be able to partner with a with a company that will sponsor it.
Yep.
Right. I mean, I don't know the companies that, maybe it's, I don't know, maybe it's the implant
Yep.
companies. That's another issue where the periodontists are having a big issue, because periodontists have almost shot themselves in the foot with implants, because periodontics is now almost seen as an implant specialty rather than a periodontal
Yeah.
specialty.
Yeah.
And many general dentists, I know loads of general dentists who place implants,
Yeah. Absolutely. Yeah. There's a
right?
high percentage. Yeah.
So why do I even have to have a relationship with a periodontist?
Yeah. We have probably, I think it's 68 coaching clients right now. And I would say, and they're all across North America, I would say
More than half.
Yeah, I would say 65 to 75% of them are placing implants. Yeah.
So what I did, I hired a periodontist to come in and place implants. Now, she was a good periodontist. So she did, I mean, we were very periodontally aware. So she also did a lot of, grafting. She didn't do a lot of osteosurgery. That's not the thing anymore. Right. But she did a lot of, free gingival grafts, pedicle flaps, what would normally be considered more traditional periodontal treatment. But I think even if a periodontist could come up with a slide deck of how to avoid supervised neglect.
Yeah. You took the words right out of my mouth. I wrote here, how can you get the GP ultra perio focused in their practice? Teach them what's happening without that perio referral. What are the consequences?
Wow.
Yeah.
So that a very important dentist, we've talked about the dentist personality, very risk averse. So part of the reason that part of what you want to include on that discussion is, how can you avoid having someone diagnosed with periodontal disease and not coming back and blame you? So that risk has to be tweaked. The reason that you're using that periodontist is actually part of your fail-safe program. Because, I mean, I don't know what it is now, but back in the day, failure to diagnose periodontal disease was the number one cause of lawsuits. I may not, paresthesia may have overtaken that. As a matter of fact, I talked to who was it? Oh, the dean. So we're talking to the dean about a lawsuit where someone had mental nerve paresthesia, and all the things that whole process brought up as the school not having an adequate sort of risk analysis or risk prevention program. Because, I mean,
Not in place.
People sue because they're not being heard. That's, to me, that, so I don't know if we've talked about this. So when I was a full-time academic, I supplemented my income by doing case analyses for attorneys. So I saw a lot of malpractice cases.
Yeah.
I've even done expert witnessing.
Wow.
Not fun.
Not fun.
But that's, so I think in a way, and so periodontists are dentists too, and they don't like being seen as the bad guys. So they don't like sounding threatening.
Yeah.
And you shouldn't, but you should present, I mean, informed consent. what can you do in your practice to avoid these problems?
And I want to point something out for the specialists listening, or for GPs who want help from their periodontists that are watching this. It's not about having a specialist come in your practice and do a slide deck on this is what an implant looks like before, during, and after. It's got to be more than that. It's got to be something that is educating your team about the risk they're taking, the patient's taking, why a referral network is important. And there's also a huge benefit to a GP practice to have a really good relationship with a periodontist. That's going to protect you, of course, like what you're talking about. And the periodontist needs that relationship just as much.
So we talked about down coding, and that too. So that's the value, I think, of the discussion to the general practice. The value is, how can you avoid those bloody prophies? What's the kind of conversation that you have to have?
Yeah.
These are, I mean, look, periodontists have an advantage. Anyone who's going to the periodontist knows they have periodontal disease. They're there for a reason, right?
Yeah.
So the periodontist can have that conversation probably a lot easier. But I would want to know, if I'm a general dentist or I'm a hygienist, what's the conversation that's happening in the periodontal office? How come they can do, 4 codes and I'm billing out 1 codes? Because the 4 codes are way more profitable, more reimbursed than the 1 codes are. When do I even things like simple things? When do I go to a was it 4910?
Yep. Periodontal maintenance. Yep.
A periodontal maintenance. When do I do that? It's maybe, look, we don't know how the dentist was educated as far as coding. We don't know how the hygienists were educated. There's always
so many practices. We get them as clients, and I'm going, why is your perio percentage at 9%? Oh, and you ask enough questions, you figure out after they did scaling and root planning, they did perio maintenance for about a year at 3 months, and then all of a sudden they're 6-month prophies, and I'm going, what is happening right now? That is not how you code this. And so there's definitely opportunities for specialists to come in and be seen as a support for the GP practices. Absolutely. So
look, you know what? I think every talk about networking. So, I'm always, I don't know if we've had this discussion. I think we have. And it's so important for a dentist to have his board of advisors from a management standpoint, also from a clinical standpoint.
The clinical side, yeah.
Right? One of the reasons, so I was eminently qualified. I was on the oral surgery department at Columbia. I was on it for 30 years. When implants came out, I was eminently qualified to place implants. I did not. And I didn't because my time was busy doing other things, and I could get this periodontist to come into my office and place the implants. But I also had relationships with oral surgeons. I would say maybe half of the implants placed on my patients were actually placed by oral surgeons. I had oral surgeons that I had very good relationships with. Why? Because I know if something ever happened, I had recourse. I had backup. And that backup is really important. I don't think a lot of dentists think about that they should have a board of advisors that are clinicians as well. Should have an orthodont. What happens when you do that Invisalign case and it gets messed up? Right?
Yeah.
What happens? The periodontal case that starts going south, the implants that you placed that failed because you didn't bother treating the periodontal disease, and periimplantitis has some of the same, risk factors as periodontitis does. What happens when you take out what you thought was that easy tooth, that simple extraction, and the root went up into the sinus? You need that backup. And that's the added value that we want. You talk about a periodontist, that periodontist can help be that resource
That's
for the
right.
practice,
That's right.
that backup.
If they're on your board, if they're you have a great relationship with them.
That's right.
So what's another, we're talking about networking, specialists getting new patients. What's another way, growth tactic for growing new patients, getting referrals, that relationship part of it? What else do you see?
So many.
What about study
Um,
clubs? Do you ever see study clubs as a part of that networking thing? Do you feel like they
sure.
work? Do you feel like they don't work?
So, it's like these business, um, there are these business networks all over the country. I'm sure you have them by you.
Hmm. Yeah.
Um, Now, some of them are limiting, so like they'll
Yeah. You can
only
only have
allow one
one. Yeah.
one person, right?
Yeah.
Study clubs are not like that usually.
Yeah.
Um, and I've I've I was involved in a study club at one point. I just got tiring.
Mm.
Um, but I've spoken
Hmm.
at many study clubs,
Hmm.
and I I I think they're great.
What's that
The problem
law?
the pro
The
the
law of
problem with study
compensation?
clubs, and so the problem with study clubs, and this goes back, we were talking about meetings because
Hmm.
I just went to the Greater New York meeting.
Hmm.
So the problem with study clubs is very similar to some of the problems with meetings, and that is it's the doctor involved and not the staff. So I don't know of a study club
Mm.
where the staff is invited.
Hmm.
It's doctors only. To
So
me,
yeah, I totally agree
that's
with
a
you.
real problem.
So so for our specialty clients, we will host a study club, once a month, once every other month, once a quarter for them. And our topics are cancellation and new patient phone calls and ideal day scheduling and case acceptance and on and on and on. And it creates value for the general dentist to come in. And we tell them every time, tell the GP to bring their staff with them, their team with them. And we have some clients where it's physical in person, and typically it's the dentist. And then sometimes it's a virtual Zoom where everybody's joining these study clubs virtually. Those are a small percentage of them. And of course I'm joining virtually, and so I'm either in the room with them. But I tell them all the time too, the specialists, have your team in the room to support when I in the meeting, to look like the expert in the room. I think it's the law of reciprocation, a law of compensation. I can't remember what that is. What is that law?
The principle of reciprocity.
The principle of reciprocity. Yeah. Give to them, give to them.
So, and there's more than that. I
Hmm.
mean, so the role of a specialist
Hmm.
is to make the referring doctor look good.
Good. Yeah.
Now, that's often not just done by the doctor, but it should be done by the staff. So, the relationship, if I'm a, Dr. Periodontist, and, Sam is my office front desk person, and I go up to Sam, um, and or the other way around. So I'm
GP.
general dentist.
Yeah. The GP's
So
office. Yeah.
it's a general dentist wants to send a patient
Yeah.
to the periodontist. You know, the someone picks up the phone
Who's
and
that person that
calls
makes that decision?
front desk to front desk.
That's right.
And if there's no relationship there,
Hmm.
and sometimes that phone call is even done in front of the patient.
Yes.
And if the person in the front desk has to explain who they are,
Mm-mm.
exactly.
Yeah. Yeah. Okay. So let's wrap about relationship between admin of the GP and the admin of the specialty. They're the ones. I mean, I managed two practices, 10 years. And when I called that specialty office and they go, "Oh, hey, Eric, how are you doing? How have you been?" Like they knew me. I have a decision to make as the person picking up the phone. Am I referring to this book of referrals or am I referring to this tablet? And I'll think, where can I get them in the fastest and who do I like the most? Who do I have a relationship with? And these GPs are leaving that decision up to the administrative coordinator, the scheduling coordinator, the patient coordinator. So absolutely agree with you. So here's the come full circle. How does the specialist develop that relationship between admin and admin?
So when they go to do the lunch and learn, that admin comes with them.
Mm-hmm. That's good.
So it's or the admin, the specialist admin takes the general dentist admin out to lunch. But there needs to be that acknowledgement that the admin is so important in the process. And there needs to be some networking that includes both of them.
Have you ever heard the donut dollies? Have you ever heard that phrase before? When you're a GP's office and the specialists bring in the donuts, like, oh, here come the donut dollies, and Christmas time, of course, we're all putting on pounds, bringing all the food to us. But yeah, no, I think dropping something off and go, hey, we want to say thank you. That is not developing relationship. It's all about relationship. Do you know their names? What's going on in their lives? You're not an interruption to them. You're an extension of their team. And how do you develop that rapport and relationship and through conversation when you're there in their office?
So obviously, as I know of lots of doctors who drop off some goodies. I think that's great if it is an entree to something else. So the reason you do it is not to show your appreciation. There needs to be you're giving them a gift. It's the principle of reciprocity. What do you want in return for that?
It's got to be a win-win.
Well, right. You do want to have, maybe it's a 5-minute meeting with the office manager. Right. I mean, so that I have this 360 interview style when I take on new clients. And it's really interesting when I try to speak to referring offices. So when it's a specialty office, I want to speak to a couple of their referring docs.
GPs, yeah.
So I had one general dentist who had no idea who the real office manager was in the practice that they were referring to. They thought it was someone who was actually a secretary. They thought she was the office manager. And this practice happened to have had a marketing person who went out, whose job it was to go out.
I still didn't
know. Yeah. You want to talk about networking. So this is a client that it's an endodontist, the specialist, but the same thing could hold true for a periodontist, or I have clients who do this with dental sleep medicine and TMJ as well. They have marketing. They have someone whose job it is to make sure that their referrers are happy.
Yes. Marketing director. Yeah.
So she
client relations
travels to each one of the offices once a month. And she looks for opportunities to develop more referral sources. So what's my avatar? What if I'm a specialist? What is my ideal dental practice? And are there some that are close by that have never referred to me? Why? And could I stimulate some referrals?
Yeah.
Or more importantly, can I get somebody who's referred one to refer two? So it's much easier to get someone who's already shown a tendency to refer to get more than it is to get a new client, a new referral.
It's 4 times harder to start from 0 than it is it's 25 times. Yeah. what's that saying? It's 25 times four. It's a 4-to-1 ratio. It's 4 times easier to continue on the path and you're on than it is to start over and try to create something from nothing. So let me make sure I got this right, because I also hear some conflict in what we're both excited about here. A marketing director or client relation specialist who goes out and creates relationship. They're your avatar. They're your face. At the same time, they may not be the same person who answers the phone when they call in, and that has to be a full circle connection. I'm thinking of a specific periodontal client, and she does an amazing job at creating buzz, but she's rarely in the office. She's out all the time creating events and developing a relationship, and just people love her. They love seeing her when she comes in the office. But when they pick up the phone and call, that's a different person they get on the other end. And so it's really important that that culture, or the just feel of who we are as a specialty office, is connected. Marketing director, client specialist, as well as administrative person on the other end of the phone.
So I tell you what I did with a client who had that kind of person who basically was never in the office.
Mm-hmm.
We changed her job description
Mm-hmm.
so that she needed to attend morning huddles.
Mm-hmm.
It's really important. And it's important for their job satisfaction as well, because part of the morning huddle is to go over who the new patients that you're seeing and where they were referred from.
Mm-hmm.
And the marketing person knows more about that referral office than anyone else on the team.
Yep.
And it's an opportunity for that marketing person to tell the rest of the team what they know about that office that they're from, where they're coming.
So do you have, so we get KPI tracking for new patients, and we do the ABC, who's the referral source. So maybe speak to that a little bit, the importance of that, why we do that.
It's so important.
Mm-hmm.
So, first of all, you can't improve what you don't measure.
That's right.
Or what measures matters, right? So
Mm-hmm.
however you say it, having that metric is really important. So not only how many new patients, where they're coming from, and I add another one, what the dollar value is
For
for that
referral.
referral
Yep.
office.
And are they
So
saying yes? Do you get a bunch of referrals who say no? Do you get a bunch of referrals who say yes? What's the dollar amount, case size? Absolutely agree. Yeah.
maybe that office takes an insurance that you don't,
Mm-hmm.
right?
Mm-hmm.
So they're sending you over all these people and they're not converting.
Or they're planting the seed before they come in. Yeah, I'm going to refer you over to Dr. Smith, but just know they don't take your insurance. And how are you coaching them to say the right things when they refer to your
So,
practice?
so that's another thing that
Mm-hmm.
you can do when you have admin to
Yep.
admin.
Yep.
You can do that as a separate lunch and learn. I mean, we had a client was a dental sleep medicine practice, and one of the patients told them what the doctor who was referring patients said to them.
Mm-hmm.
And he said,
Whoa.
he's really good.
Mm.
He's really expensive.
Mm-hmm.
So that resulted in, when we found that out, that resulted in the dental sleep medicine doc taking that other doc out to dinner and say, was that steak too expensive?
Mm.
What's too expensive?
Mm-hmm.
And just have I wouldn't do it exactly like that, but the idea is, when you, because frankly, and we deal with this a lot because we get a lot of physician referrals. To a physician, anything that involves more than a copay is expensive.
Yeah.
So it doesn't make any difference. You can have a $50 exam,
Mm-hmm.
and to most physicians, that's
Mm-hmm.
expensive
Yeah.
because they're used to paying, or they're used to their patients paying almost nothing.
And I think you create value from as a specialist to the GP when you actually teach them verbal skills. And they go, wow, my team could use some help here on their verbiage. And it actually gives back. There's more law of reciprocity involved there, when, if they're willing to accept your coaching and point of view on that, on how you recommend us, they start to unwind and realize, oh, well, how are we communicating in our own office to our own patients?
So that's a huge area where you, me, can be of value, because one of the common things in this area, and I think every market's a little different. So we do a lot of sort of dinner presentations. So it's not uncommon for let's say this endodontic group to get a sponsor. So I think the last case was Dentsply and Citibank. So this practice had recently expanded, and they used Citibank for the loan that they got. So Citibank and Dentsply sponsored a dinner at a restaurant that started off with a CE presentation. Actually, it wasn't even CE. My apologies. It was not CE. Because that requires a whole different, admin process. So, but
it was like a lecture.
But it was a practice management lecture that benefited
the GPs,
the general dentists who were referred.
Yes. And that's what we do. That's what we do with our study clubs. Exactly. I totally agree with you. And they go, oh, I don't think my people are saying it this way. So again, law of reciprocity. Let me ask you this. What's your opinion on this one? One of the things I try to, this is a very, very tight rope. This could either blow up in your face or work really well. Okay. You have to have a good one-on-one relationship between the doctors. They have to really see eye to eye on treatment planning and case acceptance and case presentation and the direction of cases to go and things. I don't think GPs like it when the specialists completely go a different direction than what they were anticipating. I don't think, and vice versa. Okay. So that's why this is risky. And you need to have your one-on-one communication down. You need to have philosophy down with each dentist. But I think, what does every dentist want more of? Case acceptance, more health, more patients saying yes to dentistry. So if I feel like as a GP, I'm giving up an opportunity to treat this patient for an implant or peri or whatever it is, I'm giving up case acceptance. It would be great to get back in return? Case acceptance. And so one of the things I talked about with specialists about is how you support that GP in your conversation with that referred patient. And you could do, Heather's amazing at sharing the sizzle. Oh my gosh, these crowns that Dr. Smith's been doing, wow, they look amazing. These margins are so, wow. You're in great hands with Dr. Smith. And I know I'm doing this root canal on this tooth in the upper right. I'm sure he's already talked about this. Make sure you go back right away in the next couple of weeks and make sure you have your appointment scheduled with him to finalize this procedure, or perio with whatever it is, crown lengthening or what have you. So finishing the implant or all on four or whatever it is. But are you referring back to the GP? So what are your thoughts on that? Do you think that's wise? Do you think that's risky?
So I think it's really smart, and I'd go one step further. So if I'm a periodontist and I'm being referred an implant, and I do the implant and the implant's getting ready to be restored, I'd say, the contour of the adjacent teeth, because that tooth has been missing for a while and the teeth moved in, the contours are a little funky. And I'm going to speak to the doctor, and he might discuss putting caps on the adjacent teeth so that you don't get a lot of food caught in between. So that doc is promoting,
the specialist is promoting the GP in something, and they get to decide if they want to do it or not. And that's the tightrope, is saying, hey, this may be something that I work with GP dentists on your behalf. I'll let them decide on that and talk to you about it. Here's what I'm thinking. I just know as someone who worked in general practice, when that patient came back with that second opinion saying, hey, I know this is something that's important for me to get taken care of. I'd like to go ahead and get that scheduled. That is huge for someone in my position to go, I want to keep referring to them. That's a big factor for me.
So let's expand on that a little bit.
Okay.
I practiced in New York, and people moved around a lot. So people were moving to different cities all the time. And I was always conflicted about, I don't know what goes on in other general dentists. Even if I know the general dentist, I don't know their work.
Mm-hmm.
So my formula for finding a new general dentist in a new area was call a periodontist, because a periodontal office will not refer you to any dentist who A, doesn't recognize periodontal disease, and B, causes problems with periodontal disease by not having properly contoured restorations. Right?
Yeah.
So, and they see it. They see the work.
Yeah.
So I said, call a periodontal office, say I've moved into the area. I'm not sure if I need periodontal treatment, but I know I have to see a general dentist. Can you refer a general dentist?
Yeah.
Now,
it's so funny. Real quick, same thing. We have an assistant moving from a client's office in Massachusetts down to South Carolina, and in our mastermind group, one of our periodontists said, have them call the periodontal office to see which office she should work for in the area.
No, have them call me. I have a really good client in South. Where in South Carolina? Do you know?
Summersville. I think it's near Charleston. I think.
Oh, it's further down.
Yeah, I think so.
So my client is in Greenville, and now actually opening up an office in Charlotte, North Carolina.
Nice. Yeah, I mean, you're right though. You want to talk to specialists because they see what's going on. I think some administrative team members are hesitant. Okay, speak to this. Even from the GP side, I'm nervous as somebody who answers the phone to quote refer you verbally over the phone, no referral pad, no exam done, somewhere for dentistry, because they somehow feel like that's a risk for them because they referred you there. And if something goes wrong, how does it come back on me? So how does a GP refer? Let's say I'm a GP and I don't see emergency extractions and I want to refer to oral surgeon, and I just say, hey, call this oral surgeon. Is that a problem from your perspective at all? You think there's risk there?
So the only risk is, how do you know that the tooth needs to be extracted?
Yes. Okay. So you have to be able to communicate with them on the phone. Hey, it would make sense to confirm that that's the right path.
So I felt obligated. If someone is referred to me as a general dentist, I feel obligated to make sure that person's making the right decision.
Yeah.
And I don't think that decision should be made when they're in pain. So I think you get people out of pain without doing anything definitive or irreversible, right? Doc, I just want it out. I just want it out. Wait, you have an infection. Let's get the infection taken care of. Let's get it calmed down. And then let's determine what the options are. So I thought that was my responsibility, and I could do that better than anybody else. Now, if you do have a relationship with an oral surgeon, I mean, I've sent patients to an endodontist, and the endodontist says, you know what? I don't think the tooth needs root canal.
And some of them won't even take, the specialists won't even take a non-referred patient, just calling off the streets, which I find just really interesting. Like, don't you want more business? I don't understand. Because then you have an opportunity to refer them to a GP. Yeah,
exactly.
Yeah,
they're missing out on an opportunity to be useful to the GP. Now, here's a scenario, since we're talking about specialists, and we're talking about some of the increasing problems that you have. What happens when the doctor that you've been having a great referral relationship with gets bought out by a DSO?
Yeah.
How do you manage that?
Because you still want the referrals. You're a little nervous about how the quality and culture is going to change.
And who knows, maybe it's a referral, one of the DSOs that has their own specialty groups. And now all of a sudden you're going to lose all of those. Now that's a That's a big deal. I
Yeah.
mean, I sort of had something very similar. So I referred my last office, I did not have an endodontist in. So I've been in lots of offices. Most of them I've had an endodontist, but the last one I didn't. And when I referred to this one office. When I sold my practice, they had an endodontist in the office. And I was almost contractually obligated. I don't remember
Mm-hmm.
what the
Mm-hmm.
wording was,
Mm-hmm.
but I was almost contractually obligated to
To
refer
refer
internally,
inside. Yeah.
unless I had a darn good reason for not. And sometimes I did. You know, if someone I said, I think I made an amendment to the language. If a patient had seen that specialist previously, they continued that relationship. There's nothing worse, by the way. If you have someone, you have to respect relationships. If you have someone who has seen a specialist, ripping that patient away from that specialist to go to a specialist of your choosing
Yeah.
can really have negative ramifications.
Yeah.
Because if something doesn't go, if something goes
And
wrong,
now that's on you.
it's
Yeah.
your right.
Yeah. Yeah. That's the risk part of it. Okay. All right. So if you're a GP listening to this, or somebody who works in GP, recognize how important the specialty practice is to your office and your team. I think we're trying to make that really clear. Network with them, create a strong relationship with them. I think this is a two-way street. And then lastly, how about, should a specialist invest financially in external marketing, SEO, Google pay-per-click, social media? Where does the more digital space for marketing play for a specialist?
So I think that's a great question. And I think that's the answer to that is, what is the likelihood that you could possibly lose your doctor referrals? I have a friend who's an orthodontist in Kansas,
Mm-hmm.
and his entire practice is built on not referrals from dentists
Mm-hmm.
or pediatric dentists, soccer moms.
Mm-hmm.
He markets to soccer moms, and he doesn't worry about any other dentists because he's totally independent of that referral pattern. I think today, if I'm a specialist, I want to try and get maybe non-doctor referrals
Yeah.
funnels.
Yeah. Yeah. I think
It's
it creates a new branch for you. And again, I think it also goes back to something we mentioned before. If I get someone off the street, now I get to bless the GP's office and refer to them. And I might sprinkle that around a bit. I remember one of our first large cases. I mean, edentulous patient, found out we did send him to the oral surgeon, had all kinds of teeth extracted, and then found out after we made the denture, he had a horrible gag reflex. Couldn't even wear the denture when we went to put it in. So then went back and did, I mean, it would be the equivalent of like an all-on 4, but he ended up with 8 and 8. It was implant bridge. I mean, it was a bridge implant case. This is back in 2000, 2001. And, you know, that patient came to, once we did that case, right? We referred him, his last name was Case, referred him to the oral surgeon. And that oral surgeon saw the occlusion that we were able to create in a perfect, just amazing, going from nothing to something in this tough case. All of a sudden, we started getting referrals from the oral surgeon's office to the GP. Guess who we started referring to for oral surgery all the time? And so, again, that trust that you build through your clinical expertise, through your referrals, through your faith in them, plays a huge role in this, right? Okay.
absolutely.
So SEO marketing, you know, I think it's worth it. Get patients off the street, business to consumer, but you're not going to want to overinvest. And I think what you're also saying is don't step on someone's toes and start marketing all on four. If you have a referral source in your area that's marketing all on four and they're getting them and sending them to you, don't start doing that same sort of marketing. Focus on periodontal, focus on saving teeth, focus on health of your gums, focus on maybe solo implant marketing, things like that. Does that sound fair?
Yeah, no,
Yeah.
you have to
Okay.
know your market.
Yes, I agree. Okay. So, oh my gosh, I have a list of 9 things I'm going to run through real quick. Lunch and
Whew.
learns. Offer CE credits. Make sure it's perio focused. Teach them what's happening without the perio referral. How are they creating issues in their own practice when it comes to the super pro fee? Supervised neglect. Number 2, study clubs. They could be monthly, quarterly, every other month. You can be clinical focused to teach them what's happening. You can also have us come in and do non-clinical focused things as well to help teach their whole team, not just the dentist. Number 3, relationship between the GP admin and the GP and the specialist admin. Make sure that there's a relationship with them, that you have lunch and learns with both, and that they're all going out to lunch and they're not just seen as donut dollies. Teach them how to refer to you. Number 4, one-on-one meetings with the dentist in each location. Make sure that's happening. Maybe even bring the admin with you. Number 5, give dentistry back to the general dentist. Refer back to them. That's going to bless them, the law of reciprocity. Number 6, have a marketing director or someone who does your marketing or client relations. Make sure they're going out once a month. And if you're getting 1 referral, try to get 2. If you're getting no referrals, try to get that momentum going. Number 7, KPI tracking. Make sure you know, you rank your referrals, how many you're getting, how many are scheduling something in your office, and what's the value of each of those referrals from that location. And if you're a GP listening to this, recognize how important the specialty practice is to your office and team. And number 9, SEO marketing, external marketing, social media marketing. Make sure you do that correctly and you invest wisely. All right. What else?
So to that,
Yeah.
for a specialist,
Mm-hmm.
solicit someone who can sponsor your programs. So whether or not it's a vendor that
Mm-hmm.
you're with, maybe it's your financial advisor, maybe
Mm-hmm.
it's your accountant, maybe it's your banker. These people also want more business,
Mm-hmm.
and they might be willing to sponsor some of the activities that you're doing to increase your business.
That's right. That's so good. Yeah. So good. Awesome. Well, thank you for joining us in our November fireside chat with Dr. Goldberg and Eric Vickery at All Star, Dr. Goldberg at Practice Perfect Systems. We're here for you. And I guess we'd also say, specialists, if you want help, we're here. We're here to help you, especially with study clubs. Yeah.
Absolutely.
All right.
Great.
Awesome.